So we're going to switch gears a little bit here, and next we're going to hear from Dr. Cheryl King. Dr. King is a professor in the Department of Psychiatry and Psychology. She's the Director of Youth and Young Adult Depression and Suicide Prevention Research Program at the Department of Psychiatry at the University of Michigan Medical School. Dr. King also serves as the content lead for the U of M Injury Prevention Center, where she provides expertise regarding the risk of suicide. She's a clinical scientist who studies clinical interventions and public health approaches to optimize youth screening strategies, risk assessments, and psychosocial interventions for both individuals and high-risk groups. Please remember to type all your questions in the Q&A box, and please join me with a warm welcome for Dr. King.
Welcome, and thank you for joining this presentation. Our topic today is universal screening for teen suicide risk. During the next 10 minutes, I hope to share with you brief information about the scope of the problem of teen suicide, some of the challenges we face with screening for teen suicide risk, and recent research that has been addressing these challenges. First, the scope of the problem. Suicide is now the second leading cause of death among adolescents in our nation. It's also important for us to keep in mind that teen males, male adolescents, account for more than 3/4 of these suicides, and that many of the young people who die by suicide have never in their life received any mental health services. It's also important, although very difficult to face, that the prevalence of suicide among youth has been increasing. And each year since 2000, we have moved from a prevalence rate of 8 per 100,000 to where we are now, which is closer about 12 per 100,000. So a very significant increase for the 15 to 19-year-olds, and a smaller increase, but proportionally just as large for 10 to 14-year-olds. We have many more suicides among older teens than among younger adolescents. There are also pretty dramatic differences between males and females. This is the male suicide rate across the lifespan by age and race. And what you can see for males is that it is quite high. The highest rate for the adolescent years are among American Indian youth. And for white Americans, these are US data, this is when the rate, just as for American Indian, it's increasing during the adolescent years, although it gets much higher in this subpopulation during later years. But compare this figure with the next one, which is designed exactly the same way. And you'll see that the female suicide rate, again, this y-axis, the vertical axis is the same. It's much lower, and there's less variation across some of our subgroups in the United States. So we do need to screen if we're going to find many of the young people at risk, but there are challenges inherent in suicide risk screening. First, we need to have a good screening tool, and a sensitive tool identifies large numbers or almost everyone who's at risk. But a more specific tool doesn't over-identify. So those it says they're at risk, they really are. And sometimes these are balanced. So our more sensitive instruments who are picking up more teens at risk often pick up too many teens. And that's a problem because we have limited resources to intervene, and we don't want to create a lot of upset if there's really no risk there. A second challenge is the heterogeneity of risk factors. What do we screen for? If we look at teens who are at risk for suicide, they have many and variable risk factors. There's no one that is either necessary or sufficient. So people are suicidal with different combinations of risk. It could vary from severe depression and anxiety and withdrawal to someone who's emotionally really labile, who is abusing drugs and alcohol, and in constant aggressive encounters with other people. So there's different pathways to risk. How do we screen for that heterogeneity? A third is that some young people will deny that they are thinking of suicide, either because they have strong suicidal intent, or perhaps the last time they shared this, the way people responded was not helpful, or they didn't feel the treatment was helpful, or they felt ashamed. And then finally, finding the males at risk. Although males account for about 3/4 of the adolescent suicides, females are more likely to seek mental health services. We see more adolescent girls in our mental health clinics, and we psychiatrically hospitalize more adolescent girls for suicide risk than adolescent boys. So we can't count on these tertiary care mental health settings to find all of the males at risk. Why screen in emergency departments? This is one of the best places, I believe, for universal suicide risk screening, because many young people come through an emergency department each year. Some of them are using it for their primary medical care, and for this subgroup, the incidence of depression, drug use may even be higher. And some of the reasons people come into emergency departments are associated with increased suicide risk. So in the emergency department, we're actually screening a community of youth that's at somewhat increased risk. For instance, alcohol poisoning, single car traffic accidents, physical altercations. Some of these are going to be risk factors for suicide. So to address these challenges, the National Institute of Mental Health funded a very large-scale grant that we have conducted in collaboration with the Pediatric Emergency Care Applied Research Network. This is something that I have led together with David Brent, a child psychiatrist in Pittsburgh, and Jackie Grubb-Phelan, a pediatric emergency medicine physician at UCSF. And our primary question with this large-scale study has been, can we develop a computerized adaptive screen for teen suicide risk? Will it do well in predicting which of these young people make a suicide attempt within 3 months of their emergency department visit? How accurate can we develop one that's accurate enough for widespread use? Why a computerized adaptive screen? Most of our screening tools in healthcare, in mental health specifically, we could call them traditional or classic screens. You've all completed screening tools like this. Everyone answers the same set of questions. Exactly. You go and you look at what your score is, and you see where you fall in terms of a risk threshold. Now, that can work fairly well if all the questions are about depression, like the Beck Depression Inventory, or all the questions are about hopelessness, like the Beck Hopelessness Inventory. But as I mentioned before, suicide risk is multifactorial. So it's a little bit more complicated to ask everyone the same questions when people may have quite different risk profiles. The advantage of a computerized adaptive screen is that it is actually adapting the number of questions and the severity of risk of those questions by the individual. So there's more measurement precision at the individual level. And to develop such a screen, we have to start with a huge item bank and a very large sample of young people who've completed that bank, and then follow them to see who makes a suicide attempt within 3 months, and develop the algorithms for prediction of those attempts. And this is based on item response theory. So in the first study, which I'm going to tell you briefly about here, this was multiple sites. We worked in 14 pediatric emergency departments across the United States. We had over 6,600 young people complete this very large item bank of all of the suicide risk factors we're aware of based on the literature published to date. So a long survey, brief scales for all the important suicide risk factors, covering everything from history of suicide attempt, non-suicidal self-injury, suicidal thoughts, sleep disturbance, bullying, and peer victimization, hopelessness, all of these constructs and more. And then we enriched a sample for telephone follow-up with a youth and their parent and measured outcomes of about 2,900 young people. And here's how the computerized adaptive screen came together and how it did. It took an average of 11 items in less than 2 minutes. For some youth, it's only 5 or 6 items. For others, it might be 17 or 18 items. At a specificity of 80%, the sensitivity was 83%. These are actually both excellent. It's not been very easy in our field to get a handle on youth suicide risk. So a sensitivity of 83% means we're picking up 83% of those who did make a suicide attempt. And the 80% specificity means we didn't do too badly with picking up those, what we could call a false positive. They weren't really at risk. These levels were better than those obtained with a commonly used instrument, the ASQ, some of you may be familiar with, and those obtained with many machine learning algorithms that we applied to all the survey questions. Now, we have since gone back to 15 emergency departments with an independent sample and validated this in that sample. So I'm going to stop there and let you know that, of course, our next goal is to be able to share more than one type of screening tool, get these out to the practitioners in emergency departments with what the triage algorithms and the decision rules might be. They can make their choice of tools and where they would like to set the risk thresholds. So let me stop there and let's open it up to questions, to a Q&A session. Thank you.
Thank you so much, Dr. King, for that interesting presentation. You started to talk about this a little bit at the end. In the chat, people are asking more questions. For example, how might this new screening tool fit within broader efforts to recognize teen suicide risk and intervene?
Thanks. I think it's really key to consider the different strategies we have available to try to recognize teen suicide risk. Many teens do not self-identify and come forward for help. That is especially true for teen males, but happens across the board. And so I think it's sometimes helpful to use more than one strategy. The one that I'm talking about, the CASI, that would be proactive screening. Universal screening, such as in general medical or pediatric emergency departments, where every youth who comes in gets screened. We're not missing a look at any of them. A second strategy is gatekeeper training. We do a lot of education and awareness activities in schools with primary care providers, where we're training the gatekeepers, the adults who are often around the young people, to recognize risk. So we do these not only with adult gatekeepers, but also with peers. And I think different settings can use different strategies. Some will be willing to use both. But the key is really then the next step. How do we get these strategies disseminated? How do we make them as feasible as possible for our emergency department and other settings? And how, if we're going to screen and identify youth at risk for suicide, are we going to take the next step and intervene? Because we don't want to implement these screening strategies unless we have the resources and the will and the operations in place to actually then conduct a mental health evaluation and work to get them linked to the services they need.
Thank you. I mean, that makes a lot of sense given how at risk these youth are. So that's really, really important points. And the next question that has come in has to do with what we've been talking a lot about it today is the COVID-19 pandemic. And are you aware of any data on any trends on suicide for adolescents at this time due to the pandemic?
Yeah, you know, a lot of people are looking at this right now. And the CDC actually did a survey. They put it out in their morbidity and mortality report the end of June. And they looked at changes in depression and anxiety from March until June. And they showed significant increases across the board. They also showed that for, I'm going to say, young adults, 25% of them had thoughts of suicide. And I think it was more than 10% across the lifespan. So there is a lot of concern given this that we might see an uptick in suicide, the trends of increase in depression and anxiety, the fact that suicide rate in the US is at an all-time high right now. And every year since 2007, there has been an uptick in that rate. And in addition to that, with COVID, we have these young people isolated and at home. And we have many homes with available firearms, and we have people at home isolated, not maybe meeting all their needs socially, or young people to be able to go out and do activities independently. So we do have a concern. We will have to wait and see the impact on the suicide rate, but definitely a concern.
Well, thank you, Dr. King. This has been very informative and important work that you're doing, so we really appreciate it.
Thank you very much.